Welcome to this explainer. We're going to jump right into a topic that is incredibly complex, widely misunderstood, and shrouded in myths: endometriosis. Today, we're cutting through all that noise and using the latest international clinical guidelines to figure out exactly what's going on and what the evidence actually says. Here is our roadmap for today. We'll start with what endometriosis actually is, dig into the symptoms and root causes, and trace the tricky path to getting a diagnosis. Then, we'll look at the medical and surgical treatments, the crucial role of holistic care, and finally, where the future of care is heading. Let's get to it.
Section 1. What is endometriosis? We really have to lay down the basic foundation here before we can dive into anything else. 10%. That number is just staggering. Roughly 10% of women and adolescent girls of reproductive age worldwide have this chronic inflammatory disease. Think about that for a second. That's 1 in 10. We're talking about millions upon millions of people dealing with a profound, often invisible health challenge every single day, completely in the dark.
So, what is exactly happening inside the body? Essentially, you have this rogue tissue. It's very similar to the endometrium, which is the tissue that normally lines the inside of the uterus, but it implants itself in places it absolutely shouldn't be. We're talking the ovaries, the fallopian tubes, the pelvic peritoneum. Out there, it drives chronic pelvic pain and acts as a massive underlying cause of infertility.
The core pathology comes down to a structural trap. A normal endometrium builds up and sheds gracefully during a standard menstrual cycle. But endometriosis lesions, they're trapped outside the uterus. They respond to those exact same hormonal cycles, so they grow and they bleed, but that blood literally has nowhere to go. This internal bleeding triggers intense inflammation, scarring, and thick bands of scar tissue called adhesions, which can actually fuse pelvic organs together.
Section 2. Symptoms and root causes. It's time to talk about the severe physical toll this disease takes, which is tragically normalized by a society that just tells patients to tough it out. Let's break down the sheer spectrum of symptoms, because we have to stop thinking of this as just bad cramps. It's a full-body experience. You've got severe menstrual and pelvic pain, absolutely, but it also severely impacts the GI tract, causing immense bloating and painful bowel movements. It creates massive hurdles for fertility, and we cannot ignore the mental health toll. Living with unpredictable chronic pain leads directly to anxiety, depression, and a severely reduced overall quality of life.
To put a human face to this, imagine a 19-year-old who has spent years being told her debilitating pain is just normal puberty. Now imagine her finally getting validated and diagnosed with superficial endometriosis. Because she caught it early, her pain can actually be managed with early hormonal therapy and lifestyle adjustments. Getting that early intervention literally changes the entire trajectory of her adult life.
So why does this happen? Well, we don't have a single proven cause yet. Science points to a multifactorial storm. There's the retrograde menstruation theory, where menstrual blood flows backward into the pelvic cavity. But you also have genetic predisposition, stem cell theories, and a profound level of immune dysfunction where the body just fails to clear out that rogue tissue. It's a highly estrogen-dependent condition, and entangling this massive, complex web is exactly why it's so hard to cure.
Section 3. The path to diagnosis. Because the symptoms overlap with so many other conditions, like IBS or fibroids, getting a correct diagnosis is famously difficult. The diagnostic pipeline usually starts with a deep dive into clinical medical history and a pelvic exam. From there, it moves to specialized imaging, like a transvaginal ultrasound or an MRI, which are brilliant for spotting deep infiltrating lesions or ovarian cysts. But the absolute gold standard? Laparoscopy. This minimally invasive surgery is currently the only way to get direct visual confirmation and take actual tissue biopsies. When staging the disease from minimal to severe under the ASRM classification, there is a critical medical fact you absolutely must remember. The stage of the disease does not always correlate with the severity of the patient's pain. You could have stage 1, minimal disease, and be in absolutely debilitating agony. Or you could have stage 4, severe disease, and feel relatively fine. The stage tells the surgeon about the anatomical spread, not the patient's subjective experience of pain. Section 4. Medical and surgical treatments. Once a patient is diagnosed, how do we treat a disease that currently has no cure? We focus heavily on managing the symptoms and suppressing progression.
Hormonal therapy is usually the first line of defense. It has to be highly individualized based on age and goals, but doctors often start with NSAIDs for pain, then move to combined oral contraceptives or progestin-based options like hormonal IUDs to thin the endometrial lining. For much more severe cases, they might use GnRH agonists to temporarily shut down estrogen production altogether. It's all about finding that perfect balance for the individual patient.
When medication just isn't cutting it, expert surgical intervention is the next step. Excision surgery, which means meticulously cutting the disease out at its root, is highly favored. Surgeons will also cut away adhesions to release organs that have been bound together by scar tissue. In selected, very severe cases, a hysterectomy might be on the table after careful counseling. But make no mistake, this surgery requires true, highly specialized expertise to protect the patient's organs.
Bringing it back to the human element, think about a 30-year-old woman facing infertility because of large, blood-filled ovarian cysts called endometriomas. There is real hope for her. Through precise, fertility-preserving laparoscopic surgery, experts can remove those cysts while saving her ovarian reserve, totally clearing the path for successful assisted reproductive treatments like IVF. Section 5. Multidisciplinary holistic care. Because this is a chronic, lifelong journey, relying on just a pill or a surgery is rarely enough. Patients need a village of support to actually thrive. This part is an absolute game changer: pelvic floor physiotherapy. You see, when you're in constant pain, your pelvic floor muscles involuntarily clench, which just creates a secondary source of intense pain. Learning to relax those muscles through manual trigger point release, biofeedback, and specialized breathing techniques is vital for rehabilitation and calming down an overactive, exhausted nervous system. We also have to treat the whole person. Integrating an anti-inflammatory diet, like the Mediterranean diet loaded with omega-3s, can seriously lower systemic inflammation. Combine that physical nourishment with cognitive behavioral therapy, or CBT, and you give patients the essential tools to actively reclaim their mental well-being from the heavy, heavy toll of chronic illness.
Section 6. The future of care. Before we wrap up this explainer, let's look at where the science is heading and clear up some dangerous misconceptions that are still holding patients back.
Let's set the record straight right now. Painful periods that make you miss work or school are not normal. And getting pregnant is not a cure for endometriosis, despite what outdated advice might claim. The proven fact is that early diagnosis, validating the patient's symptoms, and building a multidisciplinary care team are what actually improve quality of life.
Looking ahead, the international guidelines point to an incredibly promising future. We are talking about AI diagnostics and non-invasive biomarker blood tests that could diagnose endometriosis years earlier, completely skipping the need for surgery just to get an answer. Throw in novel, non-hormonal anti-inflammatory drugs that don't have the side effects of current therapies, and you've got a bright future that researchers are passionately fighting for.
Recognizing that severe menstrual pain is not normal is the first step toward timely diagnosis and better care. If you take away only one thing from this explainer today, let it be that scientifically backed truth. For decades, normalizing pelvic pain has been the biggest roadblock to getting help. Acknowledging that this pain is a warning signal, and not just a standard part of womanhood, changes absolutely everything.
With millions of people affected worldwide, how can we better advocate for early diagnosis and finally put an end to normalizing severe pain? It's a crucial question to reflect on, because improving care starts with how we listen to and advocate for those suffering in silence. Whether you're a patient, a partner, a parent, or a healthcare provider, your awareness can completely shift the paradigm. Thanks for exploring this with me today. Keep asking questions, keep advocating, and I'll see you in our next explainer.